So very importantly, we all know in a case of Ebstein anomaly, so we all know that this is the four-chambered structure of the heart. We have the right atrium, right ventricle, left atrium, left ventricle. This is the pulmonary artery and this is the aorta. So this is the basic which we know regarding the basic anatomy of the heart. Four-chambered structure of the heart: right atrium, right ventricle, left atrium, left ventricle, pulmonary artery, and aorta. Now, exam entrance question number one, the basic thing must appreciate for exam purposes, that what is the main thing happens in a case of Ebstein anomaly. So the main thing which happens in a case of Ebstein anomaly is, very importantly, this is the tricuspid valve, and there will be a downward displacement of the tricuspid valve. Study always a topic in a way that you're reading this for the first and last time in your entire life. So very importantly, there is a downward displacement of the tricuspid valve. So this is the tricuspid valve known as T1, and this is the mitral valve known as M1. And the first heart sound, it is because of the closure of the tricuspid valve and the mitral valve. So in a case of Ebstein anomaly, there is a downward displacement of the tricuspid valve. So once there is a downward displacement of the tricuspid valve, so very importantly, the right ventricle, the size of the right ventricle becomes smaller and the right atria becomes very bigger in size. So the right atria becomes very bigger than the right ventricle. So right ventricle becomes very small, very small. This is known as atrialization of the ventricle. Atrialization. Atrialization means in Hindi we say कि वेंट्रिकल बिल्कुल पतला सा हो जाता है, राइट वेंट्रिकल बिल्कुल पतला सा हो जाता है राइट एट्रियम के जैसा. इन इंग्लिश वी से एट्रलाइजेशन ऑफ द वेंट्रिकल मींस दैट द राइट वेंट्रिकल becomes so thin it almost behave like a right atrium. The right ventricle behaves like a right atrium. So that is what known as atrialization. But again, in simple words, if I talk about number one, there is a downward displacement of the tricuspid valve, because of which the right atria becomes bigger in size than the right ventricle, and this is known as atrialization of the ventricle. So once right atria becomes bigger than the right ventricle, so naturally right ventricle will not have that much pressure to push the blood into the pulmonary artery. Yes or no? Naturally, right ventricle will not have that much pressure. This is the right ventricle. So right ventricle will not have that much pressure, will not have that much pressure to push the blood into the pulmonary artery. So to push the blood into the pulmonary artery, because naturally, because right atria has taken most of the space, that's why right ventricle will not have that much pressure to push the blood into the pulmonary artery. Now what will happen there? Now what will happen, you only tell. When right ventricle, this right ventricle, it will not have that much pressure to push the blood into the pulmonary artery, so that will cause decrease pulmonary artery blood flow. That will cause decrease pulmonary artery blood flow. Decrease pulmonary artery blood flow, or also you can say something known as oligemic lung fields. That is known as oligemic lung fields. So oligemic means decrease pulmonary artery blood flow. So if I ask you a simple question, name some congenital heart disease with decreased pulmonary artery blood flow, many are there, but one I will remember, that is nothing but this one, what you call Ebstein anomaly. Okay, simple, simple, happy, happy, must appreciate for the exam purpose. So let's start again. So number one, let's quickly revise. In this class, I have understood there is a downward displacement of the abnormally tricuspid valve into the right ventricle. There is a downward displacement of the tricuspid valve, because of which what will happen, that leads to atrialization of the right ventricle. That leads to atrialization of the right ventricle. Remember that. Yes, that leads to atrialization of the right ventricle, number one. And number two, so now this also one basic stuff must appreciate. This atrialization which is happening, it is at the level of the tricuspid valve. So the atrialization which has happened, It is happened at the level of tricuspid valve, yes or no? And then that's what, so that is the basic thing we must know for the exam purpose. And I told you atrialization of the right ventricle, that means that the musculature of the right ventricle becomes thin as right atrium. The musculature of the right ventricle becomes as thin as the, very importantly, as the, what you called, right atrium. So that is the one basic thing you should know. Now, next important point we need to understand. Now, listen, this is very simple written. The effective output from the right side of the heart is decreased because of what? What do you think? Yes or no? I said the effective output of the right side of the heart, because naturally there is a downward displacement of the tricuspid valve. Right atria becomes bigger, right ventricle becomes smaller. So naturally, right ventricle will not have that much pressure to push the blood into the pulmonary artery. So the output from the right side of the heart is decreased because of number one, poorly functioning small right ventricle. Can I say that this is the poorly functioning small right ventricle? Yes, you can say that. Second important point, obstruction of the right ventricular outflow tract, because almost like, the blood from the right ventricle is not able to go out to the pulmonary artery. That is one basic thing must appreciate for the exam purpose. Achha, one more question they ask in exam regarding this. What is the ECG finding? What is the ECG finding of the Epstein anomaly? So we all know that this is the tricuspid valve and there is a downward displacement of the tricuspid valve and the right atria is bigger. Now, right atria is bigger. How do you read an ECG? P wave causes what and QRS wave causes what? So we all know that P waves causes atrial contraction, P wave causes atrial contraction, and QRS causes ventricular contraction. QRS waves causes ventricular contraction. That's it. Very simple, very easy. So when P wave causes atrial contraction and QRS causes ventricular contraction, so here the right atria is very, very big. So very, very big right atria means very, very big P waves, something known as Himalayan P waves. Himalayan P waves or tall P waves. So this is important for the exam purpose. Where do you see Himalayan P waves and tall P waves? Very importantly, the answer is Epstein anomaly. And mother would have taken which drug during pregnancy? Very common exam question. If the mother has taken lithium during pregnancy, if the mother has taken lithium during pregnancy, the baby can land up into Epstein anomaly. And why she's taking lithium? Because of what? Why the mother has taken lithium? Lithium is the drug of choice in BPD. What is BPD? Bipolar disorder. Bipolar disorder. So lithium is the drug of choice in the bipolar disorder for the mother. For the mother, remember that. Okay. So simple, happy points you should know. And very, very basic question: where do you see box-shaped heart? So this is the box-shaped heart, like a very big heart and all that. So box-shaped heart you see in a case of Epstein anomaly. So basic shape of the heart we should know. If I ask you where do you see boot shaped heart, the answer will be tetralogy of Fallot. If I ask you where do you see figure of three appearance, figure of three appearance you see in coarctation of aorta. Where do you see figure of eight appearance on X-ray? Figure of eight appearance you see in supracardiac TAPVC. In a case of supracardiac TAPVC, we see figure of eight appearance. If I say where do you see egg on side appearance? So egg on side appearance, or some book says egg on string appearance, that you see in a case of TGN. Next question, where do you see water bottle shape heart? Any idea where do you see water bottle shape heart? So water bottle shape heart you see in a case of pericardial effusion. Water bottle shape heart you see in a case of pericardial effusion. Where do you see goose neck sign? Where do you see goose neck sign? So goose neck sign you see in endocardial cushion defect. Goose neck sign you see in a case of endocardial cushion defect. So these are the important points must appreciate for the exam purpose, which they can ask in the exams. Okay. Actually, one more very interesting question. Box shape shaped heart, we all know it is seen in Epstein anomaly. And where else also can you see a box shaped heart? So we all know in Epstein anomaly, there is a downward displacement of the tricuspid valve, means the same, the main problem is regarding the tricuspid valve. Yes or no? So if the patient in a case of tricuspid atresia, in a case of tricuspid atresia, or I can say tricuspid stenosis. In that case, very importantly, must appreciate that we will see box-shaped heart, tricuspid atresia or tricuspid stenosis, that you should know. This is also a very beautiful question. All cyanotic congenital heart disease causes right axis deviation except dash, which causes left axis deviation. This is a very beautiful, interesting question. All the cyanotic congenital heart disease. First of all, name some cyanotic congenital heart disease. The answer is T, 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 T. The answer is TOF. The answer is TGA. The answer is truncus arteriosus. The answer is TAPVC. The answer is tricuspid stenosis. So in all these conditions, very importantly, must appreciate for the exam purpose, they all are cyanotic congenital heart disease. Like it's a very basic question they ask in exam. Name some cyanotic congenital heart disease. So the answer will be T, 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 T. Anything which starts with the T, TOF, TGA, truncus arteriosus, total anomalous pulmonary venous connection, or tricuspid stenosis. They all are cyanotic congenital heart disease. Cyanotic congenital heart disease usually have a right axis deviation. For example, if I talk about TAPVC also, we all know in a case of TAPVC, this is the four-chambered structure of the heart. The oxygenated blood from the lungs enter the left atrium with the help of pulmonary veins. This is normal. This is normal. The oxygenated blood from the lungs enter the left atrium with the help of pulmonary veins. This is normal. In a case of TAPVC, total anomalous, totally wrong pulmonary veins connection. So in a case of TAPVC, the pulmonary veins by mistake get connected into the superior vena cava. That happens in TAPVC. So that is why now the deoxygenated blood also entering to the superior vena cava and oxygenated blood also entering the superior vena cava. So that basically causes right atria and right ventricular hypertrophy or nothing but right axis deviation. If I say ECG is showing right axis deviation. What is the meaning of this right axis deviation? Means right-sided hypertrophy of the heart is there. If I say ECG is showing left axis deviation, that is left-sided hypertrophy. It is as simple as that. So that is why in ECG in general, if I say the ECG is showing right axis deviation, that means there is a right atrial or right ventricular hypertrophy. Okay. So all cyanotic congenital heart disease causes right axis deviation. So in tetralogy of Fallot also there is a right ventricular hypertrophy. In TRIA-PVC also there is a right-sided hypertrophy. Same story. Everywhere all cyanotic congenital heart will have a right ventricular or right-sided hypertrophy, except the answer is tricuspid stenosis. Except the answer is tricuspid stenosis, because in the case of tricuspid stenosis there is left-sided hypertrophy. In a case of tricuspid atresia or tricuspid stenosis, there is a left axis deviation because this is the tricuspid valve, right? So if there is a, this is the tricuspid valve known as T1. If there is an obstruction over here, if there is a full obstruction over the tricuspid valve, then naturally the blood whatever come in the right atrium, with the help of foramen ovale, it will go to the left atrium and left ventricle. So that basically causes left-sided hypertrophy. So all cyanotic congenital hearts usually causes right-sided hypertrophy, except the tricuspid stenosis, which causes what we call left-sided hypertrophy. Again, a quick 1 minute break. Let's just brush it up. I'll exactly start in 1 minute. Okay, very good. Just revise this. Start further. Very good. Perfect. I hope you have revised this one. Yes. Now again, a beautiful quote. See, this is you. Okay, this is you. This is such a beautiful picture where this patient has been treated by you. This patient has been treated by you. You are the first one who is standing in front of the patient. Then is the nurse. Then is all the different gods. and then this fellow is there who is just waiting. If all these people cross by, then automatically, this fellow is waiting. So being a doctor, I think it's one of the most beautiful job we can ever have. Okay, so what is the medical management of this Epstein anomaly? So medical management. So there is a tricuspid wall, there is a downward displacement. So one is the medical management and one is the surgical management. So in surgical management, so basically I will repair the tricuspid valve. Basically the tricuspid valve, this is stenosis. I will do a repair of the tricuspid valve. In the medical management, what all I can do? Do you think the baby will have cyanosis? Yes or no? What do you think? Just now we spoke about it that right ventricle will not have that much pressure to push the blood into the pulmonary artery, and the blood will not be able to go to the lungs. So that is why, yes, the baby will have cyanosis over here. And number one. Number two, if the baby has cyanosis, yes, the baby can have hypoxia. Yes, and cyanosis and hypoxia, eventually, what will happen to the baby? So in this case, one important point we must appreciate that in this case, keeping the PDA open, keeping the PDA open will be helpful. In this case, keeping the PDA open will be helpful because whatever the blood is coming from to the right atrium, from the right atrium, now we all know normally blood goes from right atrium to right ventricle to pulmonary artery and to lungs. Here the problem is right ventricle does not have that much pressure to push the blood into the pulmonary artery. Yes or no? So that eventually what happens, the blood is not going to the pulmonary artery and the blood is not going to the lungs. So I need to make the blood go to the lungs. So what will I do? So I will, so the blood, so the blood which has come from through the right atrium, from the right atrium, the blood goes to the left atrium with the help of foramen ovale, with the help of foramen ovale. And from the foramen ovale, the blood goes from right atrium to left atrium to the left ventricle. From the left ventricle, the blood will go to the aorta. And from the aorta, very, very importantly, with the help of PDA, the blood will be able to go to the lungs. That is very important. That is why, in this case, in the medical management, you will give L-prostadil, which is the prostaglandin, which is a PGE1 analog. Okay. Please remember very importantly, placenta. Placenta secretes PGE2. P for placenta, P for PGE2. Placenta secretes PGE2, which keeps the ductus arteriosus open. I'll repeat again. Placenta secretes PGE2. It is endogenous in nature, which keeps the ductus arteriosus open. It is endogenous. PGE2 is endogenous. If I have to give something from outside to keep the PDA open, that is PGE1, that is L-prostadil. Did you understand? I'll repeat again. In this condition, very importantly, L-prostadil as a medical management I would like to give so that the PDA remains open, so that the blood from the right atrium goes to the left atrium, then left ventricle, then the aorta, and then the PDA, and then to the lungs. So these are the important points you should know for the exam purpose. Now, in the medical management, number one, we spoke about the PGE1 infusion. That is one thing I have told you. Second important point, yes, we can do all these things. We can use the mechanical ventilation. If the baby has a cyanotic congenital heart, cyanosis basically can lead to metabolic acidosis and shock. So definitely, yes, very importantly, number one, PGE1 infusion. Number two is mechanical ventilation. And number three, you can use inotropes. So various inotropes we have dopamine, dobutamine. Remember, whenever you're talking about the heart, in a case of cardiogenic shock, the dobutamine is the preferred inotrope of the choice. MCQ. In the case when the heart is involved now, dobutamine is always preferred. Why? Like in myocarditis, any heart problem, if it's in heart issue is there, I want to pump the baby's heart, so that way dobutamine is very good. Remember, dobutamine has a B, and beta 1 receptor basically acts on the heart, causing tachycardia. Dobutamine has a B, and beta 1 receptors act on the heart, that cause tachycardia. In a case of cardiogenic shock, very importantly, dobutamine is the drug of the choice. So number one, very importantly, PG1 effusion, then you have mechanical ventilation, then you have inotropes, and always we give diuretics basically to prevent the cardiac overload. Diuretics we basically give. So these are the very importantly PMID. Take a Prime Minister of the India, that is the mnemonic for the medical management of Epstein anomaly. I'll repeat again. Prime Minister of the India is the mnemonic for the medical management of the Epstein anomaly. Prime Minister, P for PG1 infusion, M for mechanical ventilation. India, I for inotropes, and D for diuretics. And in the surgical management, I have told you basic surgical management. Now, this is three things. Yes, in this, they're the Prime Minister of the India. In the medical management, the mnemonic was Prime Minister of India. Here, the mnemonic is best friends. For the surgical management of what we call Epstein anomaly, the mnemonic we have is best friends. Now, B for very importantly, Blalock Tausig shunt. This is very quite interesting. Blalock Tausig shunt. So, we all know in a case of Blalock Tausig shunt, in general, we know we do in a case of tetralogy of Fallot. You remember tetralogy of Fallot? Now, tetralogy of Fallot patient has a pulmonary stenosis. In tetralogy of Fallot, there is a pulmonary stenosis. And basically, what do? I connect my pulmonary artery to somewhere else. Basically, I connect my pulmonary artery to the subclavian artery. That happens in a case of Blalock-Taussig shunt, pulmonary artery to the subclavian artery. And here also theory in Epstein anomaly is almost like the same only. In Epstein anomaly also, just because the right ventricle does not have that much pressure to push the blood into the pulmonary artery, in Delhi, if one road, there is no traffic, very less traffic, slowly that road starts getting damaged. Or I can say slowly in that road, the flowers and trees and forest and everything will start to grow because that road is no longer being used properly. So that is why same story. Eventually, you're gonna have pulmonary stenosis in Epstein anomaly, and there to prevent that, I will do a surgery known as Blalock-Taussig shunt, where I'm gonna connect my pulmonary artery to the subclavian artery. That is one thought process. Second thought process, I'm going to do the Fontaine operation. Now, what is Fontaine operation? Fontaine operation we can do if you remember in a case of HLHS. What is HLHS? Hypoplastic left heart syndrome. If you remember, we had studied a disease known as hypoplastic left heart syndrome. As the name says, hypoplastic left heart. So left atrium is not working, left ventricle is not working, and aorta is not working. There is a hypoplastic left heart, full heart, left side of the heart. In that, basically remember, as the left side is not working, we did a mnemonic known as no good flow. Yes or no? Can I say there will be no good flow in hypoplastic left heart syndrome? Yes, exactly. There will be no good flow because there's of the hypoplastic left heart. So in no good flow, we do something known as, I'll only say the flow right now, that is Fontaine operation. In Fontaine operation, what do? We connect our inferior vena cava to the pulmonary artery. We basically connect our inferior vena cava to the pulmonary artery. And here in this case also, we're gonna do first of all, why? What is the rationale of connecting the inferior vena cava to the pulmonary artery? Same story, dear. The baby is almost developing a pulmonary stenosis. Yes or no? Just now I told you that in Epstein anomaly, if I talk about, just because there is a downward displacement of the tricuspid valve, right ventricle does not have that much pressure to push the blood into the pulmonary artery. So what will happen? Eventually, it will develop pulmonary stenosis. So what my body will do to prevent right ventricular overload, to basically prevent congestion to the right ventricle, because right ventricle is not able to do the work properly, no. So basically, to prevent the problem to the right ventricle, I am going to connect directly my inferior vena cava to the pulmonary artery. So best just remember this point, to prevent the right ventricular issues, because right ventricle is having a problem. He is not able to push the blood into the pulmonary artery. So somewhere I have to push the blood into the pulmonary artery. How will I push the blood into the pulmonary artery? I will directly connect my inferior vena cava to the pulmonary artery, known as Fontaine operation. So that basically prevent right ventricular issues. It will prevent. So same like a Blalock-Taussig shunt, which is focusing on pulmonary artery, and same as a Fontaine operation, which is focusing on the pulmonary artery. The mnemonic we have is best friends. B for Blalock section, best friends, F for Fontaine operation, and one is Starney's operation. In latest again, very rare, rare of rare. Starney's operation. In Starney's operation, basically directly final, you repair the tricuspid valve. In Starney's operation, it is a proper closure of the tricuspid valve, which whatever that stenosis there, no, that issue basically has been resolved in Starney's operation. So that is one thing you should know. So what all I did today, this is the for the Epstein anomaly in past cardiology. This is the picture. So in Epstein anomaly, the treatment we're talking about, if is the baby deeply cyanotic or is the baby having asymptomatic child? Deeply cyanotic. Deeply cyanotic means, what do you mean by deeply cyanotic? By deeply cyanotic means there is a pulmonary stenosis. I told you, there is a downward displacement of the tricuspid valve. So right ventricle does not have that much pressure to push the blood into the pulmonary artery. Eventually, it will develop pulmonary stenosis, oligemia, or I can say right ventricular outflow tract obstruction. Yes or no? So there is an obstruction at the tricuspid valve, and here I did a Beloc section where I connect my pulmonary artery to the subclavian artery. Okay, that is one thing. So yeah, that we can do a Starney's operation also. I told you like that, and we can do a Fontaine operation also. And in general, if the child is asymptomatic, and right ventricle is fair enough size, it's good size. If the right ventricle is fair enough size and the baby is asymptomatic, we do something known as two ventricular repair. Something known as two ventricular repair. In one segment, I will reconstruct the tricuspid valve, which is known as Danielson or Carpentier. And in one, I will do the tricuspid valve replacement. So first reconstruction of the tricuspid valve, and there is a tricuspid replacement. That is a two ventricular repair seen in done in asymptomatic children for Epstein anomaly. Now, this is the life on social media. This is the life on social media. What we show is a different projection altogether, and behind something else only is happening. So this is the reality of life. Make sure you are not that one. Please remember that. Again, a quick 30 seconds break. Have a quick glance of whatever I told you. This is very important for the exam purpose. And in the meantime, I'll just connect my laptop to the charger. Just 1 second. Give me. I'm connecting the charger. Okay. So the next topic of choice, let's do this. The next topic of choice we have is syndromes with radial deficiency. Syndromes with which has a problem in the radial bones, radius and ulna. So let's start this topic. This also is very easy. Before starting any segment, we always have a quote, and the quote for today is very importantly: "Don't judge me by my success. Don't judge me by my success. Judge me by how many times I fell down and got up again." So, very importantly, we should not judge anyone on any behalf. Life is really beautiful. Life is so amazing. I mean, I can't even tell you in words. I mean, all you have to do is find the way of finding happiness. You should know how to find happiness in your daily routine. Successful is the one who enjoys his daily routine. The time you realize that instead of regretting and repenting and blaming, if you just enjoy and find joy in small things and find and make things joyful, then you can do anything. you know that's what I can say. Okay, this child, look at this bone. This is the humerus, and there we have the radius and ulna, right? If you see on the another part of the story, this one, this baby, this is humerus. Now this is specifically only one bone is there, only one bone. So this is a very classical picture where they ask in exam, very rare of the rare questions, that that is syndromes associated with radial deficiencies. Syndromes associated with radial deficiencies where the radial bone is absent. So we have a simple mnemonic HTVF. In HTEF, number one, we have something known as Holt-Oram syndrome, number one. Number two, we have something known as TAR syndrome. What is TAR syndrome? That is thrombocytopenia absent radius syndrome. Thrombocytopenia absent radius syndrome. So thrombocytopenia absent radius syndrome, that is TAR syndrome. V for vectoral anomaly. V for vectoral anomaly. So and F for Fanconi anemia. This is the last segment, F for Fanconi anemia. So now these four conditions are there very importantly are the syndromes associated with or conditions associated with the where radial deficiencies, radial where radial bone is absent or something problem is there, radial deficiency. Now Holt-Oram syndrome. Firstly, Holt-Oram syndrome is very easy. Let's go one by one. Holt-Oram syndrome. One thing I will remember for exam, that is absent thumb. One thing I will remember for the exams. Number one is absent thumb. Number first thing. Second thing, first is absent thumb. Second is which is the most common congenital heart disease in Holt-Oram syndrome. It is ostium secundum type of atrial septal defect. It is secundum. Ostium secundum type of atrial septal defect is the most common congenital heart disease in Holt-Oram syndrome. Holt-Oram syndrome, number one. Number two, in Holt-Oram syndrome, I told you absent thumb. It's almost like a five fingers. One, two, three, four, five. One, two, three, four, five. Five fingers. It does not have a thumb. That's the absent thumb. It's like five fingers. It doesn't have a thumb. That's the strange part. And this is number one, thumb is absent, and number two, it is TBX5 gene mutation, and thumb is absent. Okay. And I told you the most common congenital heart disease is ostium secundum type of atrial septal defect. Okay. And it is autosomal dominant inheritance. This is autosomal dominant inheritance condition. If I ask you a random question, name some other condition which are autosomal dominant. The other condition which are autosomal dominant, the mnemonic is MAT match. M for Marfan syndrome, A for achondroplasia, A for achondroplasia, and T for Treacher-Collins syndrome, T for Treacher-Collins syndrome. So all these conditions, very importantly, they are autosomal dominant inheritance. And now this Holt-Oram syndrome also is autosomal dominant, number one. Number two, yes, exactly. Phocomelia can also be seen in the syndrome. Phocomelia, limb defects is there. And most importantly, I told you instead of thumb, there is a finger. Thumb has just two phalanx, and the patient is gonna have three phalanx. Okay. And now we do not do a surgery for this. Proper surgery. I'll make a new thumb. Basically, instead of making it look like a finger, I'll make it like a thumb. This is known as polycization. This is known as polycization, where you have this anatomical repair you do. So that is known as polycization. I'll show you in picture also. This one. So this was the finger like that, and then they made a proper thumb out of it. So that is one something known as polycization. So yeah, that is known as polycization. Please remember that. This part is done. Now TAR syndrome. TAR syndrome, as I told you, the line that is thrombocytopenia absent radius syndrome. Thrombocytopenia absent radius. The name itself says T for the patient has thrombocytopenia, okay, which is present at birth, but it improves over time. It improves over time. That's it. And yeah, this is what and that's how the patient comes to us. This is my patient only, and many patient comes to us like this. That is radial deficiency, and that you need to think about Holt-Oram syndrome, TAR syndrome, Fanconi anemia, and vectoral anomaly. Okay, so TAR, I told you, it is thrombocytopenia absent radius syndrome. The patient will have thrombocytopenia. This one you should know, it is autosomal recessive inheritance. That is autosomal recessive inheritance, and thrombocytopenia absent radius. A for absent, A for atrial septal defect. Atrial septal defect. So atrial septal defect is the congenital heart which is seen over here. So this very classical picture. See, this second bone is not there only. There is very classical image-based question they ask in good quality exams. The question ASD is associated with all except infective endocarditis, stroke, arrhythmias, and pulmonary hypertension. So remember, infective endocarditis is associated with ventricular septal defect. It is less associated with atrial septal defect. VSD is more commonly associated with infective endocarditis. Okay. Last but not the least, now the class is over. We have the vectoral anomaly. Vectoral anomaly. So vectoral anomaly, the mnemonic itself is nothing but known as vectoral. So V for vertebral anomaly. You will check the vertebra of the patient. A for anorectal. You will check that. C for cardiac checkup. T for tracheo, E for esophageal, R for renal, and L for limb anomaly. So whenever the patient comes to you with a what we called absent radius syndrome, radius means kind of a upper limb, lower limb problem. So limb anomaly, if the baby is coming to you, you need to do a complete blood checkup. You need to do a complete blood checkup, mean blood as in complete body checkup, where you known as vectoral anomaly. You check for the vertebral anomaly, anorectal anomaly, cardiac, tracheo, esophageal, renal, and limb anomalies. So these were the important points of the conditions radial deficiency syndrome associated with radial deficiency. So I'll repeat again. That finishes this class. Thank you so much, everyone. So this is a Nelson line. Must appreciate for the exam purpose. So the syndrome associated with radial deficiencies are Holt-Oram syndrome, thrombocytopenia, absent radius syndrome, vectoral anomaly, and Fanconi anemia. That's it.